All right, let's dive right in. Today, we are tackling one of the absolute cornerstone procedures in modern orthopedics, knee joint arthroplasty. It's a surgery that has quite literally given millions of people their mobility and their lives back. We're going to break down the fundamental principles of how it all works.
So, here is the central question we're going to unpack today. What are the core principles of knee replacement surgery? By the end of this explainer, you're going to have a really solid, high-yield understanding of the entire process, from the initial indication all the way through post-operative care.
And here's our game plan. First, we'll cover why we even do this surgery. Then we'll get into the nitty-gritty of the components and materials. After that, we'll look at how these things are actually secured to the bone, what the recovery process looks like, and of course, the potential complications you need to know about. We'll wrap it all up with the key take-home messages. First up, indications and basics. So, what's the rationale here? Why would we consider completely replacing someone's knee joint? Well, as with everything in medicine, it all comes down to the underlying pathology. The number one driver, by a huge margin, is advanced osteoarthritis. You know what this is, that chronic, irreversible degeneration of the articular cartilage. Now, for early stages, we're obviously managing conservatively, but we're talking about the end stage here. This is when arthroplasty becomes the definitive treatment. We're talking about patients with that classic night pain that wakes them up, significant axial deformities, think varus or valgus, and those debilitating flexion contractures that just cripple their range of motion. Okay, so we've established the why. Now let's get into the what. What exactly are we putting into the patient's knee? That brings us to section 2, the actual hardware, the components, and the materials they're made of. So right off the bat, you've got to understand the difference between a total knee arthroplasty, a TKA, and a unicompartmental knee arthroplasty, or UKA. A TKA is what most people picture. We resurface both the femoral and tibial sides of the joint, the whole thing. A UKA, on the other hand, is a more targeted procedure. It's for when the damage is isolated to just one compartment, medial or lateral. So you only replace that single part, preserving the rest of the healthy knee. Now, the implant itself is made of a few key parts. You've got your femoral component, a tibial component, and sometimes a patellar component too. The standard design, the workhorse, involves a highly polished metal alloy articulating against an incredibly durable plastic. And that plastic is ultra-high molecular weight polyethylene, or UHMWPE. That metal-on-poly combination is absolutely essential to the implant's function and, just as importantly, its longevity. So we've got our components. The next huge question is, how do we attach them to the bones so they stay put? This brings us to section 3, covering fixation methods. And this is a really critical decision that the surgeon makes in the operating room. There are really two main philosophies here. On one side, you have cemented fixation. This uses polymethylmetacrylate bone cement. Think of it like a medical-grade grout that provides immediate, rock-solid fixation. On the other side, you've got uncemented or press-fit fixation. These implants have a special porous osteoinductive surface that basically invites the patient's own bone to grow right into it, creating this amazing long-term biological bond. The choice often comes down to the patient. Cemented is common in older patients with weaker bone, while uncemented relies on the strong healing capacity of younger, more active folks. All right, the surgery is done, the implant is in, but the work is far from over. Let's shift gears to section 4, post-operative management. And let me be clear, what happens after the patient leaves the OR is just as vital for a successful outcome as the surgery itself. In those first few hours and days, it's all about close monitoring. The first 24 hours are often spent in a higher-level care unit. You'll typically see suction drains left in for up to 48 hours to manage any hematoma. And of course, prophylactic antibiotics are running for that same period to prevent surgical site infections. You can really think of early management as resting on 3 core pillars. First, limb positioning. Getting that knee moving from full extension to 90 degrees of flexion is crucial. Second, and this is non-negotiable, is thromboprophylaxis. We have to prevent those dangerous blood clots like DVTs and PEs. And finally, effective pain control. If the patient's in pain, they won't mobilize, and early movement is absolutely key. Now, here's a number that you should really lock into your brain. 6 weeks. While protocols can vary a bit, 6 weeks is that classic milestone for when we typically initiate full weight bearing on the new knee. That time is so important for letting the bone heal and allowing the implant to integrate properly before it has to take on the patient's full body weight. Okay, let's move on to a really important topic, especially for your exams: potential complications. No major surgery is risk-free, and it is absolutely our job to know these risks, anticipate them, and manage them. So let's start with the general complications, the ones that can happen with pretty much any joint replacement. Infection is the big, devastating one, and it can be early or late. Aseptic loosening, which is often driven by microscopic wear particles from that polyethylene liner, is a major cause of long-term implant failure. And of course, you've got risks like periprosthetic fractures, DVT and PE, and potential nerve or vessel injury during the surgery.
Beyond those general risks, there are complications that are really specific to the knee. A stiff knee with limited range of motion is a huge cause of patient dissatisfaction. Instability can happen if the ligaments aren't perfectly balanced during the procedure. You can also have a residual axial deviation, which can lead to abnormal wear. And an injury to the extensor apparatus, the quad or patellar tendon, that can be truly catastrophic for function.
Okay, we have covered a ton of ground. So let's consolidate everything into our final section, the key take-home messages. This is your high-yield summary, perfect for revision.
Let's recap the highlights. The primary indication is advanced osteoarthritis. The implant components are typically metal on polyethylene. Fixation is either cemented or uncemented. Post-op priorities are DVT prophylaxis and pain control, with that magic number of 6 weeks for full weight bearing. And for complications, remember the big three: aseptic loosening, infection, and limited range of motion.
And I'll leave you with one final thought to consider. We've talked a lot about getting that implant fixed securely to the bone. But beyond that initial fixation, what is the single most important factor that determines if that implant is going to survive for 10, 15, or even 20 years? Really think about the materials, the mechanics, and that long-term biological response. It's a key piece of the puzzle. Thanks for joining me.